Hi, Mike Gibson, Kirk Garratt, and Ajay Kirtane coming to you live from SCAI here in San Diego. Kirk, you're president here at SCAI for a few more minutes.
Just a little longer.
Just a little longer. Great to have you on the show. Ajay, we're talking about ORBITA today. Where are we 6 months after the initial presentation of the results?
I think many people have processed it, post-processed it, and beyond, but there's some new and interesting data that will be coming out at EuroPCR. I think a lot of people are looking forward to some of the physiologic-based analyses of the trial. And so we need to see what that's going to show. I can't speak about it further in that regard, but I will say that the trial is an important trial. It's the first sham-controlled trial of PCI that's been done, and it's notable in that regard, and brave of the investigators to be able to do it despite the challenges of funding. I think the main issue relates to one of context, and that's something Kirk and I have talked about a fair amount, and maybe Kirk, you want to speak to that a little bit, and then we can have a discussion.
Excuse me, sure. Well, I couldn't agree more. It's a great trial. It's a great work product, and the authors are to be congratulated for having taken it on. It wasn't an easy thing to get done. The questions, of course, that came up immediately in the wake of ORBITA, and which remain to some degree with us today, are how generalizable are these findings? Do the patients enrolled in this study truly represent the sort of patients that we have to manage daily? And how much did we really learn about the utility and role of invasive therapies in patients who have relatively few symptoms and who are stable on an aggressive medical management program? I look at ORBITA and I think what I take away here is a confirmation of the information we've had previously and that have directed guideline statements that tell us that these patients really ought to soldier on with medical therapy, and you should reserve invasive care for those patients who have breakthrough symptoms despite good medical care. In that regard, won't it be interesting to see the physiologic data? We will have to rethink our premises a bit if it turns out that many of those patients who had no or little in the way of symptom once they were established on under good medical care, indeed still had evidence of significant ischemia in a lesion. I think that will be a very provocative thing if indeed that's what the findings show.
Right. Can you at least tell us what some of the questions that'll be asked are?
Yeah, I mean, I think main things are that people criticize the trial for enrolling patients that had physiologically normal findings in the cath lab. But the idea of the trial was to kind of replicate current clinical practice. In that case, physiology is not used in the majority of cases that are done. And so additionally, I think the investigators felt that if they had a positive result of the primary endpoint and then they had a range of physiologic indices, they could then determine if there was a correlation. The challenge is that when you have a negative primary endpoint, then to further get positive data from substrata becomes even harder, and so I think it'll be interesting to see what the spread of the values is. I don't think, honestly, that the physiology will change what the primary results are because the primary endpoint was negative.
Well, but the primary endpoint says something about the treatment effect. The physiology doesn't care about what the primary endpoint was. I mean, the physiologic questions stand on their own, I think.
Yeah, and I think we'll see how that ends up playing out. The overall, though, a degree to which patients were ischemic, if we recall from the trial, was minimal. We're talking about debridement stress echo scores that weren't that abnormal. Even the Duke treadmill score was not that abnormal. So these are not super high-risk patients that we're considering. But for investigators and for clinicians, there are folks out there who feel that on the basis of FAME2, even if you have a single vessel disease with an FFR of 0.75, that there's clear and compelling data for a patient without symptoms that we ought to treat it. And I think this analysis will help in those types of patients for sure.
Yes.
Is there an official SCAI position on the results?
Well, we've of course made public statements and published documents detailing our interpretation and sense of the study. I have been criticized rightly that perhaps the first document produced, our initial press release, was defensive in nature, and believe me, that wasn't at all the intent. The intent was simply to acknowledge the study, thank the authors for doing the work, and to then put on the table the question about generalizability and whether or not we'll be able to better interpret and use these data once we gain the added understanding of the data set from sub-study work like the physiologic analyses that are going to be presented shortly. I would add that one of the things that we have done in order to assure our membership as well as the population at large that SCAI is sincere when it says that it wants to understand best practices and embrace them and align behind them. In order to make that clear, we've invited the authors of ORBITA to join members of SCAI leadership and produce an editorial. And the editorial wouldn't be then to rehash the numbers and try to think about different ways of looking at the data. Rather, the editorial would be intended to make clear that the global value of this sort of initiative needs to be appreciated. We need to work hard to integrate the findings into our best clinical standards. And SCAI will stand in lockstep with that, regardless of the nature of the study, regardless of the findings, and regardless of who's involved.
I think the authors, too, have been actually vocal in this regard with regards to the medical therapy and the choices that patients have in these regards, too. I mean, not everybody wants to be on 3 antianginals, including a beta blocker, which makes people feel terrible. And we're not talking about a short period of time. This is lifelong antianginal therapy to suppress symptoms. And so for many patients, if you can do a procedure safely and then withdraw antianginals in those folks, not a question not answered by ORBITA, that might be better. And the investigators themselves have made this point too, and I think that's why the contextualization of it and this initiative that you're leading is going to be very important.
Great, guys. Well, thanks for joining us, and thanks to all of you for joining us here live from SCAI 2018.